Well, thanks everybody for coming. It's fantastic to see you all travelling so far. So I'm going to talk about meniscal injury mainly because in the last 2 years there's been a lot of increasing data and delineating the role of meniscal surgery and not to operate and the rehabilitation a bit. So it's a changing field. So I was going to talk about why I like to repair the meniscus, or you could also call it why I try to repair the meniscus, and you can see that sometimes can be a problem. So the science is evolving, as I've said, and there's probably about six to eight publications over the last 12 to 18 months which are sometimes turning around what we think and do. Just like to remind you all of what the meniscus look like. You've got the larger medial meniscus, and it sort of cups on this axial view with the femur removed, the lateral meniscus. So I just want you to keep that in your mind, because some of the video I'm going to show is important just to remember what it looks like. Now there's a couple of concepts I think are important, and sometimes it's difficult to actually apply the concept to a patient. I had a patient today who, he had a degenerative but perhaps traumatic meniscus injury as well. He was 48, bit of pain, and then he thumped it and twisted it, and it went from being grade 1 sort of pain out of 10 suddenly to 8, 9 out of 10, and it hadn't settled over 6 weeks. So I was chatting about traumatic versus degenerative, and some more and less repairable, but he said, well, aren't I traumatic? And I said, well, you really are degenerative, but you just had an injury chucked on top. So sometimes these are nice concepts when you present it, but actually when applying it in real life, sometimes fall down a bit. Now this is a really nice 3D little picture of a meniscus, and just describes the patterns we have. Half the time the meniscus injuries I see don't really nicely fit into any box. Okay, they're usually combinations of and when I write complex, sometimes it's all over the shop, you can't even tell, because it's 3D, and half these diagrams you see are all nice little 2D representations of a 3D shape. But we talk about longitudinal, they're a peripheral tear. We talk about horizontal, or a cleavage tear. We talk about radial tears, or a split, which are at a right angle to the hoop fibres of the meniscus. And if you all remember, the meniscus is composed of a collagen of 3D matrix, and interposed with that with a ground substance. So it's almost like, for want of a better description, like reinforced concrete, where the collagen fibres are like the steel, and the ground substance is almost like the cement, except it's flexible. So it's like reinforced steel, and that's what gives it its strength. The trouble is when your collagen starts to fail, and you get these tears and degeneration and those sort of things. And the flap tear is like, they're usually symptomatic for patients, but there again, the description. So the traumatic ones tend to be longitudinal, particularly when you've got a torn medial meniscus, and your radial, where you tend to get like a compression injury, typically when someone comes down, land and have a valgus event to their knee, and they radial tear the outside portion of the lateral meniscus, or when they actually tear their ACL, and then whole knee subluxes in the lateral femoral condyle, smashes into the back of the lateral tibia and transects the lateral meniscus. I've had 3 or 4 of those injuries just in the last 2 weeks. Completely transected lateral meniscus, purely due to, or near transected, purely due to a transection radial tear. And the flap tear, so that tends to be degenerative. So when you look at these injuries, you can usually tell, it's the age too. So traumatic lesions tend to occur with a history of trauma and younger, and degenerative lesions typically don't have a history of trauma and are older. The other concept that's important is whether it's vascular or avascular. I'm sure you'll remember that the peripheral third of the meniscus has a blood supply, and so there's a better potential to heal, and the inner 2/3 does not. So we're sort of struggling sometimes to get these avascular tears to heal. And tears that are complete in the avascular zone, like those flap type tears, have a lower potential to heal. Okay. So when I look at these tears, the 3 thoughts that I have are, should I leave this tear alone? Or can I repair this tear? Or I can't repair this tear, but is this person symptomatic enough to warrant you know, an arthroscopic meniscectomy. And that's sort of the way I'm looking at all meniscal tears, basically, and thinking that through. And that's simplistic, but that's a nice way to start, because if I see someone comes along with just a cleavage tear and not much pain, there's no point touching them. They're not going to be any better post-surgery. The same goes for smallish radial tears. I just leave those alone. You know, you can't repair them. They're not usually that symptomatic, and I just try and leave them, and I'll show you why. Similarly, I had 2 of these today. Guys had these degenerative flap-like parrot tears. They cause a lot of symptoms. They're not really big, and they usually flip under the meniscus, and they annoy people like crazy. And so they're the ones, you can't repair them. I've tried, they just don't work. And usually the people are symptomatic enough to warrant intervention. Now, these longitudinal tears I try and repair, and I try and repair as many as I can, particularly those that are in the vascular zone and in younger patients. The biggest bane of my practice is that active person, you know, it's probably a degenerative tear, but it's still a bit vertical, the history of trauma, and they're heading towards 40. Their healing potential is much less than somebody who's, you know, 15, 16, 25. So the age does affect the outcome. So this is a really nice cadaveric study that came out about 18 months ago, because I was taught as a less grey-haired registrar or a less young consultant that radial tears of the meniscus were basically like a meniscectomy. You might as well just go and trim it and make the person happy. But this recent study, which was elegantly done, looked at contact pressures of the meniscus, and they created radial tears in cadaveric models. And what they found was that actually, even with a 90% radial tear, so you can see here on the left, the person, or the meniscus in the cadaver, has had an increasing radial tears created, and in fact the contact stress, so yellow is not too bad, and if you go into red, that's bad, because too much red means that you're overloading the articular cartilage, and it's going to get accelerated arthritis, because there's a point of happiness. So or cartilage likes a Goldilocks environment. You need a bit of loading but not too much loading, and if you damage a meniscus, then the loading goes up. Okay, so I used to think that a radial tear was just like a meniscectomy, and it just didn't work, but that's actually not true. So this study shows that if you have a radial tear to 90%, it does increase it a bit, the contact stress, but if you then go and try and saucerize it, it goes way up. So I try and leave those alone. I had a young fellow who's like 22. This week he's got a full radial tear of his lateral meniscus from a motorbike accident, and they often develop lateral meniscal cysts, and he came in, he's in pains like 10 out of 10, you know. And I said, you just can't not have, you have to have surgery on it, but I don't touch the radial tear. What I do is go into it, preserve the meniscus, try and repair it, and then go outside in and inside out and take out the cysts, because it's usually the cyst that's causing these guys the pain. Just like Terry's Gerser lesion, it tends to recur. So there's about a 20-25% recurrence rate. So the best thing is when someone comes in with those and go, does it hurt? I go, nope. I go, fantastic, see you later. We have one of the Titans players who went on to play in the UK at the end of his career, and he had a massive lateral meniscal cyst and radial tear, and he had actually failed trying to remove the flap tear and trying to repair it. And I just basically injected it with cortisone, every 3-4 months, and I think eventually someone banged it and ruptured the cyst and it went away. So, and he had very little pain. So the other problem with meniscus injuries, if you trim it or they have a meniscectomy and somebody's already in varus, this is a Korean study from a year ago. So we don't want people to be the varus or valgus, because it puts too much stress on either side of the joint. So if you've got a meniscus tear and you're already in a little bit of varus, this study showed that you actually go back and fall into further varus, and that's bad because it's like a forward feeding event. You get increased loading, tear your meniscus, then you get actually more loading on a damaged joint, so it pushes people forward. And a lot of time I'm doing osteotomies on these type of guys who damage their meniscus. They're getting accelerated medial compartment arthritis or in varus, and a lot of the time I'm doing opening wedge tibial osteotomies just to unload and push the weight back into the lateral compartment to slow down the arthritic process. So again, if the person's got malalignment, particularly bad. And I always say beware the medial meniscectomy in the patient with varus, or the lateral meniscectomy in the patient with valgus, because you're actually going to push it forward. So I always say, in my mind, reconsider meniscectomy in patients with no or mild symptoms, because you not really want to treat their MRI, you want to treat the person. Now, if someone says it only hurts when I run, that's difficult to treat. Now, there's been 2 studies in the last 9 or 10 months looking at degenerative meniscus tears. Both very controversial. There's been a lot of unhappiness in other journals about them because they're supposedly flawed, but I'll just talk about them because I think they're really important to know about. One was a Korean study. They had 102 people, randomised controlled trial. They all had degenerative meniscal tears, so horizontal tears. That one I showed earlier, so a cleavage type tear. And symptomatology varied, but they treated half with a meniscectomy and the other half they treated with rehab. And no surprise. Now, there was some crossover, so some people who had were assigned to the rehab group actually failed rehab and then had to have surgery. I think it was about 4 or 5 out of the 50, so it wasn't huge numbers. And then, but long term, the 2 groups, excluding the crossover patients, there was actually no functional difference long term. So that was an interesting study, but this goes to show degenerative cleavage tears don't want to touch, which I think everyone knows anyway. This is a much more controversial study, came out about 2 months ago in the New England Journal of Medicine. It's so controversial that the Journal of Knee Arthroscopy's last editorial was, "Does the New England Journal of Medicine hate knee surgery?" And it's interesting, it's from Finland, and it took them a long time. It took about 5 years to recruit all the patients. The 146 patients all had degenerative medial meniscus tears. They've all been waiting 3 months or more for treatment. And then what they were randomised to was either meniscectomy or a sham procedure. So the sham procedure, they went in, they scoped the knee and everybody, and then they looked at the meniscus and they said, okay, half of you are going to have a meniscectomy and the other half, we're just going to make strange noises and push the shaver around, but not actually touch the meniscus. And then there was some crossover again, but not that much. And at 2 years, it was actually, they couldn't show a large functional difference. So there was a bit of a difference. The meniscectomy group were slightly better, but not enough to be statistically significant. Now, it's got a big thing called selection bias. So if you imagine if you had a big sore knee that was swollen and was clicking all over the place and you're in 8 out of 10 pain, there's no way you're going to agree to be in a randomised controlled trial. You're going to have a fake operation. So you have to have people who haven't got much pain in the first place and who are actually settling anyway to get it. So there's a big selection bias. So there's controversy about it because they're saying, look, you're just treating people who have minimal symptomatology, which we know anyway. So they probably should say that arthroscopic partial meniscectomy in patients with minimal symptoms who agree to be in a strange study don't get better. Because there's people you see that come along, like they come in, they've had sore knee for 6 weeks and it's settled down, the pain's 1 out of 10. There's no way you're going to touch them. But these guys got people enrolled in a study. It's very hard to enroll patients for studies because it's almost like I'm trying to enroll people now, and I'll talk about it at the end, for a study that doesn't even involve surgery, it just involves some riding a bike. It's impossible to get people to come. Oh, where do I have to do that? And is that going to cost me any money? Yeah. So meniscal tear and MRI doesn't have to be treated if the patient's symptoms are minimal. I think that's well known. We get people ringing the rooms all the time. They've got grade 4 severe osteoarthritis and they're 78. But their MRI shows a meniscal tear, and that's what's causing the problem. But truly, they're probably the meniscus tore and extruded in 1942, and the reason the knee is sore is they've got advanced knee osteoarthritis, and the knees just totally had it. But it's very hard to change people. It's much harder to talk a person out of an operation than in. This is a person I literally last year only had pain when he ran, and I said, look, you shouldn't have a meniscectomy because I'm going to probably tell you not to go running after the surgery. And this went on, and he's a keen triathlete. He said, but if I really want to keep going, I said, look, if you have surgery, you're going to, I don't think it's necessary, and you're probably not going to be able to run anyway, and your pain's going to be the same. So the next day, I got this 2-page letter writing about all these symptoms and why I didn't. And it's like literally I didn't tell him anything at all. Like, he'd completely forgotten that because he's walked out and he didn't get an operation, and he wants an operation, and he wants to be better. So it's a very powerful placebo effect, and there's a very powerful belief that surgery is going to make you better no matter what. And that actually probably isn't true. And it leads a lot of people to be unhappy. Unhappy with their surgeon. So you've got to start making people happy and then picking people who are going to be happy from surgery because you don't want them unhappy afterwards. So meniscectomy will make you worse is a very difficult concept to sell. I find it quite hard. Okay. Now, basically, if you tear your ACL, that makes all meniscal injuries traumatic. Okay? So none of that stuff that's gone beyond really counts for that. Because if you tear your ACL and you've teared your meniscus, either at the time or later on, by definition, your meniscus injury is essentially traumatic. Unless you tore your ACL, 10 years ago and your knee's got arthritis. But if you tore it recently, whatever you're seeing is actually traumatic. And I know this sounds bizarre, I had a 70-year-old lady who had a great knee, tore her ACL doing something, and then bucketed her meniscus, bucketed middle meniscus. And I actually reconstructed her ACL and repaired her meniscus. Now I thought I was the biggest quack. I'm thinking, God almighty, I'm going crazy. But the only other option was to go in and do a total meniscectomy, and that would just have wrecked her knee, and I would be coming back doing a total knee very quickly. Because at 70, you do that to somebody, it just destroys their joint. You do it to somebody at 24, probably another 20 years. You do it to somebody at 70 and just chop out the whole meniscus and leave them with no ACL, it would just wreck their knee within 2 years. Okay, so in her, I actually repaired her meniscus. Fingers crossed, I hope it works. Because I said to her, look, do you want to do this? Do you want to do that? She was very keen not to have a knee replacement. And yeah, at the end of the day, an ACL reconstruction and medial meniscal repair is not that awful compared to a knee replacement. So when you tear your ACL, your medial meniscus fails, not usually at the time of the ACL rupture, but due to repetitive microtrauma because the knee is unstable. And the lateral meniscus is typically torn at the time because the whole knee basically dislocates and the lateral femoral condyle smashes into the lateral tibial plateau and crushes it. And I'll show you examples of both. So this is just a knee. The actual meniscus is okay. This is the medial meniscus. I'm actually just doing a pivot shift while arthroscoping the medial compartment. Can you all see that? That's reduced. That's sublux. I'm actually just doing a pivot shift. Bang, bang. So this person doesn't have a meniscal tear. But what in daily life this person does with no ACL, that's constantly pivoting and subluxing their knee. And what happens is they get micro tears of the posterior horn of the medial meniscus. And it's just a repetitive micro event. Eventually they turn up and they get a bucket handle tear. So the bucket handle tear is not a one-off event. They don't go from being a normal meniscus and an ACL deficient knee. They actually go from being slowly accumulating micro tears to it just pops out one day and doesn't go back in. And I had a girl today who had an ACL about 6 years ago and it's a little bit not where you'd want it. And she's got a mild pivot. It's not bad enough to revise, but she started to tear her medial meniscus. I looked back at her notes, she had her notes from when the ACL was done and no medial meniscal tear. And now it's developed one. I actually repaired it today, but fingers crossed, because on table she's got a little bit of a pivot, and this is what happens. So it constantly abrades it, okay? Now, this is a case, this is another case. This is a guy who I first met when he was 45. He's torn his ACL. Not unstable. Doc, I got no instability. I've had this ACL tear since I went skiing 10 years ago, okay? And then he came back 6 years ago or 5 years ago with a bucket handle tear. No ACL, bucket handle tear. I think he's now like 54. And you look at that. That's not you see it's all frayed. And the meniscus just looks like a mess. So I'm now at bone school. So bone school is where the orthopaedic registrars. And I presented this case. I said, okay, I stopped it here. I said, right, you got a 54-year-old. His arthritis is only 1 or 2. He's got this chronic ACL deficient knee and he's got a bucket of medial meniscus. And what would you do next? And they all wanted to go in and do a meniscectomy. I said, does anybody want to repair this meniscus and do an ACL reconstruction? No. I said, are you kidding? And I said, oh, he's really old. I went, okay. They're all like 28 to 31. I said, listen, 54 really isn't that old anymore, okay? I'm almost 50. So the key here is, I actually reconstructed his ACL and he sends out those spam letters all the time. Called Flex Geo, and I asked him to take me off the mailing list, but he's always going on. But I know his meniscus hasn't torn because at 5 or 6 years, because the other day he was going on about globalization of something, but he had in there and going on about drug companies and there's a big conspiracy and all this sort of stuff. At the end of it, he goes, oh, I don't hate all doctors because I still like that surgeon who reconstructed my ACL and repaired my meniscus. I'm not making this up. This is in his group email. So it hasn't failed yet. And that's made me allow, I guess, to have the guts to go and repair this 70-year-old lady because I thought I was being a complete quack. Okay, all right. So you can see here, this ACL doesn't work. The meniscus just looks shocking. You look at this, go, oh, this is terrible. No way you can repair this. But you put the ACL in, and it's a study we did, and lo and behold, you stop the knee subluxing and falling all over the place. And so you stabilise the joint, and then tension it, and then the meniscus just looks totally different. The knee doesn't sublux. You don't get the tibia coming forward on the femur. And so we tension it. So we've done a study now. We did 70 ACLs with meniscus tears, and so that's the same knee. And the meniscus, now you know, obviously you haven't repaired meniscus, but you look at that, you can see it looks different. It's not scrunched up. It actually was easy to repair. Okay. So half the time the guys go in, look at the meniscus, and it looks terrible. The knee sublux, go, we'll just chop it out, we'll do the ACL, we'll come, and it's too late. So you've got to do it the other way around. So we've done a study. We had 70 patients ACL meniscal tear, and we took a photo of the meniscus before we put the ACL graft in. Then we had a photo of the meniscus after we put the ACL graft in, and then we had 10 orthopaedic surgeons rate them. They were blinded, and they all basically said that the meniscus looked much better with the graft in and more repairable compared to beforehand. So we're about to submit that. Okay, so that's that.
You always do the ACL repair before you do the
Yeah, well, this makes it so much easier. It's really hard to repair a medial meniscus with no ACL. The knee just pops all over the place, and you're yelling at your assistant. And it's not, you know, hold still and do this. And, it's really hard, and so it's easy when you put the graft in. It's simple. So. No one's described that. When I first submitted as a case report a couple of years ago to a journal of knee surgery, and they weren't interested, so we had to go and do a big study. Okay, I'll go back here, hang on. So this is, what's that? Okay, this is another case. This is just showing you, I guess, different injuries. This is a person who is a semi-professional surfer. He had a hyperflexion injury, and I guess I'm showing this because it's becoming increasingly common to see for some reason, and B, you can actually repair this. It's a rude avulsion of the medial meniscus, so his whole posterior horn of his medial meniscus is actually ripped out of place. I'll just pause this. You look here, that's his medial meniscus. It should be attaching, but it's not. See his lateral meniscus posterior horn's attached? Not there. Okay, and then the video shows this. So this is the arthroscopic picture. So that's his PCL, back of his medial condyle. That's his posterior horn, his medial meniscus ripped off. It should be attached there. Yeah? And that's not good because he's only like 21 and got to try and repair these. So I'm only showing this because it's a nice video of a technique. So essentially ran a little loop up and then lassoed it and pulled it back into place. Now you would never have picked this injury without MRI. Like, I'm sure before MRI, a lot of these saw me, but I didn't see them because they're sort of globally a bit sore, but not really. But you can't tell. And then you get the MRI and go, oh, you've ripped off your posterior horn of your medial meniscus. So we're basically stitching and then pulling it back into place. Can you see it all coming back in place now? Can you see that? There we go. There we are. So even those sort of things are actually repairable, and there's a good blood supply there. He also works as an air conditioning technician. He's already back, I sorry, a month post-surgery, he's back working without a problem. So those sort of complicated things are repairable. All right. Now this is the sort of injury you get when you tear your ACL and you chop your lateral meniscus. This is last week. I've had 3 or 4 of these lately. So this is a really nasty tear of the medial meniscus. So you're probing it there. Can you see that? I'll pull it forward. So that's the tear coming around. I'm pulling it all the way forward. Can you see that? Now, that just goes to show, that whole flap tear, different things, how would you describe that? It's like a shear, crush. It's awful, like that meniscus. If you don't try and do something to that, it's going to wreck that poor person. So the other thing about this is the knee is incredibly aligned on the lateral meniscus. If you touch it, it's bad. The knee gets accelerated arthritis. And the medial meniscus, it's not so bad, but the lateral, awful. Really rapid destruction. You see 17 or 15-year-old who tore their lateral meniscus at 12, and they've already got moderate arthritis at age 17. Bad stuff. Okay. So this is just to show that you can repair this, but it's tricky. You have to, come in from 4 ways, and you have to have an assistant who actually can hold the camera and help you out, which unfortunately I never have. So it's always, I'm trying to push the assistant with my shoulder or my elbow to knock them into position so I can see what's going on. So I'll show this. I've got to give a lecture in Sydney a few weeks' time on advanced meniscal repair techniques, and I actually videoed for that. But it just goes to show these lateral meniscal complex tears, you can actually repair them, and they actually often heal in combination with an ACL reconstruction because a lot more vascularity, there's a lot more blood and a lot more stem cells come into the joint, you can get the thing to heal. And I'll show you that because I've got another example of a player later on I'll talk about. So I can repair this tear, and that's probably what I'm thinking if I can, particularly when the ACL is torn. The biggest clinical problem is the innately poor healing ability of the damaged meniscus, particularly degenerative ones. It's very frustrating, you get a 40-year-old active person and then suddenly they bucket their medial meniscus. And the chance, you repair and do everything right, the chances are sort of 50-50 whether it's going to heal. It's really hard to manage that and try and get the thing to heal. I always try and roll the dice, and if it works, it works. If it doesn't, well, I don't have any worries about going back, and because usually you at least save more meniscus than if you take the whole thing out. I'm currently using a bone marrow aspirate. So intraoperatively, we take out bone marrow and we inject it into the repair site. This is just this afternoon. I did this video. I did this 3 times this afternoon. So that's like a bone marrow thing. You take all that crest bone marrow out of it. It's got a really sharp, pointy thing. You see that? This is the arthroscopic picture. And we aspirate heparinized about 8 to 10 mils. It's the same thing I'm using for bone marrow concentrate out of the pelvis when we're doing microfracture and we're trying to concentrate it right down, but this is just trying to get a blood clot, and that's just injecting it. So we're trying to improve the innate healing ability of the meniscus and looking at doing a study on that. So when we're doing a microfracture and we're doing osteotomies, we're actually going one step further. We're taking 60 mils of posterior iliac crest graft with the same thing, same trephine, and then spinning it down and concentrating and just extracting the cellular layer and then injecting that with platelet-rich plasma. We're doing osteotomies to try and improve the microfracture outcomes and trying to basically restore the biologics of the joint. I'm doing about 1 a week. I've got another one tomorrow morning. We're doing an ACL simultaneously. A lady's about 50 or 48. She's actually a physiotherapist. Okay. Now, this is a case. I show this because I've got the video of the injury. I've got the MRI before the injury, I've got the MRI afterwards, and the intraoperative pictures. So it's a nice case of actually what you can get to heal if it all goes well. So this is he's a semi-professional rugby league player. It's him catching the ball and stepping, and that's his right knee as he's injuring it. And then, so it doesn't, not much. You think, oh, it's not too bad. I was surprised. I actually saw the MRI before the video of this. So it's a bit of a step. He's got a massive step on him. The camera could hardly keep up, but there he goes. Falls over. Okay, you wouldn't think that's too bad. Anyone? No? Okay. So he's got that horrendous notch. That's probably the worst I've ever seen. I'll just show that. Here, look at that. So that's essentially the same shape as back here because that's been smashed into that. And his lateral meniscus happened to be in the way and it's chopped in half. And it's flipped out here. So that's the end of his lateral meniscus posterior horn, which should be over here. I've tried to push these back down, but I've never been successful because you just can't get it back down. And what happens also, they get chondral death there. So you come back 4 or 5 years later, and even if you push it down and get it nice, they just get a big grade 4 ulcer there. So it's actually better just to be punched in and left. And then if we get a grade 4 ulcer, it's not the end of the world. And treat it, expect like the Macy graft or something. I've tried to push them back down, but I realised that was actually being too caring. Which can be bad as a surgeon because you do things probably aren't such a good idea. So the bad thing here is that this is awful and not so cool. So took him to the operating theatre, and this is a nice little pictures here. Okay, so this is the intra-operative pictures. I wasn't, at the time, I was thinking this is really bad, and I kept thinking it was bad. I didn't actually take a photo of the lateral meniscus in the lateral gutter, which I should have. I managed to flip it back down, and this is a picture I took in the top right here, of the pictures with the probe. Can you all see that? And that's actually with the meniscus sitting there, but it's sort of, oh, thank you. It's, but that's actually not attached to anything. That's his sort of ripped off posterior horn, and it's just free floating. That's the fracture. Now, so what I basically tried to do is I thought, well, I might as well try and repair this, which I've done in the past. So can you see that's it again, but with sutures in it? And using that same technique I showed earlier with the loop, didn't video it, but and did an ACL reconstruction. Now, thinking this is all bad, he's going to need a meniscal transplant if this doesn't work, and it's going to be the end of his career, etc., etc. So we splinted him. I normally split pill for a couple of days post ACL. Like I would do it on a Thursday. They'll be back. I'll get them on Monday and I'll get them out of the splint. We just splint them now so that the quads, wait for their quads to recover. They get a bit of quads insufficiency, just to remind them they've had an operation. But they can come out of the splint when they're resting. So I don't really get too excited about that anymore. But I actually kept him in the splint for like 2.5 weeks because I was very worried. And so that's just a close-up. So you can you see the green sutures there? So I've lassoed the posterior horn, I've pulled it back down and try to attach it back down, okay? So that's lateral condyle. I'm looking across where the notch is here. I haven't put the ACL in, so you want to try and, when you repair the meniscus, if it's a medial meniscus, you want to do it after you put your ACL in. If it's a lateral meniscus, you want to do it first because your ACL graft gets in the way. Because that's actually, the ACL graft's going to go right there, so you actually can't see very well. So lateral meniscus, you try and do it first. And that's it. So I pulled it back down and managed to stitch it thinking, see how this goes. Okay, so then he got really stiff, and at 4 months I had to take him back to theatre because he was only getting about 90 degrees of flexion. He had a big fixed flexion deformity, and so he had arthropobrosis, but I actually wanted that to happen. Oh, he had a medial meniscus bucket handle tear too, which I repaired. So this is at 4 months. Can you see that? So what's happened is that his lateral meniscus has sort of has healed and regenerated itself. So those green stitches you can't even see anymore. You can just see something there. And it actually almost looks normal. I couldn't believe it. So if you're 19 and you basically dislocate your knee and rip out your lateral meniscus, there's a reasonable chance of it healing. I'm not quite sure why. So that's why I put the bone marrow concentrate when I repair meniscus. I don't want to do an ACL because you get so much blood and bone marrow in there it doesn't matter, but I do when I just have a straight meniscus repair. Okay. The biggest clinical problem remains the innately poor healing characteristics of the damaged meniscus, and people are working on scaffolds and augmentations and all sorts of things to try and get the things to heal. But the younger, better, traumatic, better. So, why do repairs fail? And we come to realise that repairs don't fail because of the suture strength. So everyone gets carried away about, well, we do it in orthopaedic meetings, what sutures you use, do you do inside out, all inside, all this sort of different ways of doing it, do you use anchors, do you use fast fixes? It really probably doesn't matter because it's all about the vascularity, you know, and the biomechanics, okay. Now, there is a nice, so how to rehab a meniscus tear is really, up until recently, a completely evidence-free zone. You could go from putting someone on a cast for 6 months, 6 weeks, 6 months, whatever, or doing nothing. And there was evidence that perhaps it didn't matter. So this was published last year, and this is again a cadaveric study. They put little X-ray beads in an artificial meniscus tear and then repaired it. And so one was on one side of the tear and then flexed people through to look to see did they gap when you bent the knee up. So I did what happened to the meniscus tear when you bent the knee and started doing things to it. And to their surprise, we used to think bending the knee caused the tear to separate, so we didn't want to bend the knee. But in fact, what this found was the exact opposite happened. They compressed the tear together. So, I don't know if you can read that, but acute posteromedial meniscal tears, repairs of vertical matrix recesses do not gap, but actually compress. Okay. And then at ISACOS, which is International Arthroscopy Knee Surgery meeting in Toronto last year I went to, and they presented their randomised controlled trial. So these guys from Sweden had people that repaired medial meniscus, and half of them they braced like normal, standard protocol, and the other half they did nothing to. They said, off you go, do what you want. And the failure rate in the two groups was the same. Okay, same failure rate. So I have changed what I do a bit. I don't brace them so religiously anymore. Having said that, for a while there I just didn't brace them at all. I said, off you go, do whatever you want. Now my next door neighbour, who's 40 something, bucketed his medial meniscus surfing as house thread broke. And I said, okay, you don't need a brace or whatever. And then about 8 weeks post-surgery, I looked through my kitchen window and he was doing a Tom Cruise slide, literally across the floor on his haunches, 8 weeks post-meniscal repair. So now I've gone back a bit to change, because I realise if you tell people to do whatever you want, that's within reason, that's bad. Okay. So I brace them for a bit if they're a big bucket, but I don't brace a lot of other things anymore, unless I really want them to get stiff like that young guy. Okay. All right. Now, I think that's come to the end of the meniscal repair talk. Is there any questions that they'd like to ask? Or anything like comments on? And I'm going to chat just a bit about this study while you think of it. So, at Bond and the Research Institute, which is a fund I've set up, one of the directors of, we're doing a randomised controlled trial looking at high intensity interval training for patients with knee arthritis versus a moderate intensity program. I mentioned it's hard to get people to enrol in a trial. Well, that's why I'm presenting this. I thought it'd be easy, but it's difficult. People go, innately say, no, I don't want to be involved in research. And I can't spend an hour to go and listen to learn how to ride a bike. So if anybody has any patients with mild to moderate arthritis who are happy to go on an 8-week rehab program and be randomised to 2 groups, and it's a home-based program, you can just go to that website, we can just direct them there, and they can register online, and then the students at Bond will take it further and work with them. Okay. Thank you. Now, if you have any questions, or if you want any of those articles, just email me at that address and I'll just create a Dropbox link and I can send it to you.